Next, we're going to shift our focus a little bit towards how are we really going to get there. We've learned a lot today about the initiatives with CCSVI and multiple sclerosis. A lot of theory, some data, certainly very promising data, not just coming from one individual. Paolo Zamboni certainly has shook the MS community in a great way from really thinking outside the box. And Mark, I love your analogy of thinking outside the brain and looking at the jugular veins. But where do we go from here? How do we collectively gather data that is comprehensive, that is meaningful, and that can actually lead to initiatives that can lead to policy change, et cetera, and treatment changes as time goes on? So CCSVI and multiple sclerosis, connecting the dots, and we certainly come back to that. The obvious question really is, what brings us together here? Physicians from different specialties, healthcare providers, healthcare advocates, physician advocates, and patient advocates, and patients themselves. And you've heard a little bit about this, and I'm not going to spend too much time on this, but there is a history with multiple sclerosis. And part of the reason it's got a history that dates back into the 14th century is often when we do not have an adequate treatment, or often when there is a disease process that is very complex and requires comprehensive treatment, we don't quite hit that right out of the park on the first time we try to find a cure for it. It was the 14th century when the earliest description of signs symptoms of multiple sclerosis were discovered. In 1868, Charcot first connected the symptom to a syndrome. It was in 1930s that Dr. Putnam in Boston, a neurosurgeon, connected the dots a little bit in trying to do a canine experimental model and trying to piece this together in seeing central venous stenosis as outflow obstruction in MS lesions. In the 60s, we thought it was all related to an allergic response. In the 80s into the 90s, it has become autoimmune and certainly has a lot of validity, a lot of drugs that are targeted towards that work well. They have limitations, certainly. And here we are in 2009 into 2010 with Paolo Zamboni initiating the concept of CCSVI. Now, why is all this so confusing? And this slide should be really familiar to everyone here because the clinical manifestations and the differential diagnoses of multiple sclerosis are vast. And it is often said that no two patients with multiple sclerosis have the same symptoms, and that certainly adds to the complexity of this. There's no cure for MS. Certainly we have current treatments, but as we heard earlier by Dr. Lenahan, they're immunosuppressives, and immunosuppressive treatments certainly have a price to pay with side effects. The concept of CCSVI is pretty encouraging. It certainly has brought us all here together, and if you go on the website and you go to MS organizations, there's an incredible amount of initiative and focus on this entire concept. There's a thought process that it just cannot be that all this is not valid. Maybe not all of it is valid, but we need to get to that common ground through good research in figuring out where and how we treat and identify CCSVI and its implications, if there are any, in multiple sclerosis. And obviously all of the speakers here today tend to think that there are, and I'm sure the audience has similar values. Where do we go from here? Now, all good research, and there's been a lot of research that's been done over the past several years, and the concept of CCSVI is not new. It's not just a few years young. As we talked about, this dates back tens of years. But all good research leads to more questions than it really does to answers, and that's kind of where we are. To simplify what's really going on here and help people understand, the images on MR are really important, but at the end of the day, it comes back to central venous stenosis. Amount of blood that's going into the brain, amount of blood that's coming out of the brain, and if there's any reflux or impedance of that blood coming out, and does that have an impact on what's going on? So if you take a look, this is just an animation. This is what the right internal jugular, left internal jugular, a lot of collaterals in between, and you saw a lot of beautiful images of all the collaterals. I'm not going to show you that on this. I'm simply going to focus on major target vessels, which are the major draining vessels on the anterior surface of the neck that drain the brain. And obviously they join the confluence to become the innominate and then the superior vena cava, and here's the azygous vein. Now, certainly we've seen cases and cases of stenoses. What's the etiology? We don't know. What does this really mean? How much impact does this really have? And these are the questions that really need to be answered. Can we just do an angioplasty, percutaneously inflating a balloon within a vessel to open it up? Sure we can. We've done that for decades. Have we had good results? Well, in certain situations we've had good results. In veins, that's not necessarily a place where we're going to have long-lasting results that are going to be very promising. Stents have clearly evolved from being used in the coronaries to being used in the periphery and being used really in biliary systems and a lot of other places in the body. Stents are scaffolding that allow the vessels to stay open for a longer period of time. They apply radial force, persistent radial force that allow the vessels to stay open to some degree. But with angioplasty and with stenting, there are failures. Now, they're not frequent, especially in the early time period, but in longer follow-up, the failures become more so frequent. And these can lead to clot generation and thrombosis. Virchow's triad, which is a very famous triad, which talks about what forms DVT, clots within the deep veins. And it's stasis of blood. It's three concepts: stasis of blood, it's simply a hypercoagulable state and an injury to the vein. Now, not all patients with multiple sclerosis. As a matter of fact, most patients with MS don't have a hypercoagulable state. But the other two things, which is an injury to a vessel and stasis of blood flow, are two components that are very real. The flow dynamics in the jugular vein change. They change when somebody's upright versus when somebody is lying supine. And in supine, the flow is much greater than they are in upright. The vertebrals that are in the back of the neck tend to drain the blood a lot with greater flow rates when patients and people are upright. We saw Dr. Hackey talk about the impedance when there is stenosis and the flow rates, and how the flow really has to diminish to almost zero and then accelerate to push out of the jugular veins. Or even in normal subjects, the flow is really not that fast. It's slow and steady. And those things certainly can lead to a place where you can have persistent injury, stagnation of flow, and development of clot. And that's going to be the bane of our existence when it comes to treatment. And I will really say that today I would assume that we all agree that the treatments we have available today on our hands are really not the treatments that are going to evolve in the next 5 years, 10 years down the road. As a matter of fact, if we're simply just doing angioplasty and putting in simply bare metal stents as we do today for these patients 10 years from now or 5 years from now, in cases of multiple sclerosis and CCSVI, we have probably failed in evolving to the appropriate level of treatment that's going to be required. So what are the other options?